My presentation is really focusing on the more common safety questions and concerns we get surrounding immunomodulators and biologics. And I'd say if I had to pick, old school therapies that have been around, they're pills such as mercaptopurine. It's been around since 1980 in terms of its publication in our space. And yet, 18 years later, there was a new therapy with anti-TNF or infliximab being introduced. And yet, despite, for example, infliximab being around for now since 1998 till 2000, almost 2016, we still have this idea and the perception by physicians, patients, everybody, that a pill that's been around since 1980 probably carries a safer edge to it than an IV or a subcutaneous therapy that's only been around for 17 years. So how do you break that apart? How do you break that down? And since we've had more exposure to these drugs in combination, for example, how to tease out what is really driving the safety. So my discussion is really focused on a review of the common side effects that we all talk about associated with some of the more common therapies like azathioprine or methotrexate, and focus a little bit on introduce the concept that maybe, just maybe, most of the risk tied to use of biologic therapy is tied to the combination in use with the immunomodulators, as some of the safety signals we've seen when using combination are applied solely to monotherapy of these immunomodulators. So how to break that apart? That's really my discussion. And then talk a little bit about what are the more common things we're seeing with the anti-TNFs and not focus so much on malignancies because they're extremely rare events, and why focus education on that. So I always laugh, a family will say, well, really, okay, you make it sound like there's nothing I need to worry about, as a parent saying back. And I say, well, say, what do you see? And I say, well, the more common things I see are rashes, maybe some staph infection, things that I'll be reviewing today. So it's interesting that when you break it down and I have to think clearly about how to communicate to the audience about what are the more common side effects we're seeing and not get caught up in this malignancy inertia that everyone wants to be in without even knowing good data. So I'm trying to break that down and get off that top of the building and bring us down to the ground level. Some would say I'm maybe on a rampage to get rid of thiopurine from the arsenal of pediatrics, only because I've had more and more experience with it, and a few more concerns that have come about within our patient cohort that I've been dealing with, and then emerging data that's come about that is suggesting that risk is more tied to combination. So I'm trying to break that apart and try and communicate it effectively so that it doesn't look like I'm completely against the use of one therapy over another, but just factually explaining to physicians the same way I would explain to patients. I think everybody needs to recognize that there are some common themes that are going to be facing us in 2016. I think the biosimilar story, albeit not necessarily tied to pediatrics, but in general, is a topic that we all need to start communicating about and recognizing that they're going to be a part of our space, and how to think about it both in use in pediatrics and adults, and how long will it be before it gets implemented? Does it need to be tested in pediatrics? That's an unclear answer as of yet in the US, for example. So dealing with that with my colleagues, thinking about this idea, are we ready to treat to target? This concept of mucosal healing is the end game of what our treatments are targeted for, and are we ready to implement that into a pediatric-based practice? And then the idea of tight control and disease monitoring. So once you diagnose, risk stratify, meaning prognosticate, use your therapy, optimize the therapy that you've chosen, and be very nimble at the idea that you can keep resetting and re-striving to reach that target, I think is extremely important.